Hello students, I hope you have clear idea about stage 1 and 2 physiotherapy management from the previous video. In this video, we are going to learn about stage 3, which is infant to toddler. So now tell me, what do you mean by infant? So babies with age between 0 to 1 year are called as infants. Clear? Now, what do you mean by toddler? So when babies start walking, that is from age 1 to 2 or 3 years, babies are called as toddler, right? So now what are the component of stage 3? So first you have to prepare the child mentally and physically for the upright standing and mobility. So this phase is essential as child will start learning standing and walking. And some patients with spina bifida are having associated neurological condition, so which might lead to delayed development. Therefore, it is crucial to prepare child and family mentally. Uh, Moreover, child is weak, especially lower limb. So you have to prepare them physically by means of strengthening and using other protocols. Now, next, check on the MMT every 6 to 12 months and reassess the functional motor. So here I would say that as a physiotherapist, you should assess the patient, then set your goal. Always set optimal goal, then plan your treatment to achieve this goal, right? Now, again, after achieving goal or after a period of time, reassess the patient, then reset your goal, then replan the treatment to achieve your new goal, right? And this method you can use for any patient, okay? Any neurological condition or orthopedic condition, you always have to follow this, right? uh, until you make the patient independent or achieve the uh, optimal goal which is helpful to the patient or which they want, right? Now, what are the probable goals for this stage? So first is maintaining range of motion, prevent contracture, facilitating movement and motor control, improve strength of weak or paralyzed muscle, independent sitting, supported standing, and functional transfer. Therefore, by the end of this stage, child can at least sit independently and have optimal range of motion and strength for the next level, right? Now, um, in stage 2, we learn about importance of positioning, right? Especially prone positioning. So in this stage, you also have to encourage the child to assume the prone position during the play and sleep, right? To assist the stretching of tight musculature. But here it is very difficult to make toddler to be in one position. So mostly toddlers are get irritated or annoyed very easily than the infant. So you have to constantly encourage the child to assume the position, like engaging them in activity while in prone position. So they uh, make activity enjoyable for them, right? Now you can also from this stage you can also prescribe the splint, assistive devices and splint, so such as resting splint for the lower extremity, for the positioning, uh, maintaining range of motion, prevent contracture, and better alignment. Okay. So in this photograph, it shows tricks to encourage the child to assume prone position. In first picture, child is prone on mother's belly and mother's hand on the gluteus maximus. So by placing the hand on gluteus maximus, uh, we can slightly press down the hip, so it will stretch the iliopsoas muscle and it will helpful. Okay. Now in the second picture, there is a older child in the prone position with lower limbs split. Okay. And playing with the favorite toy. So as you make the child activity enjoyable, child will assume a particular position for longer period. Now in third photograph, uh, if the child is having tight adductor muscle, so these are some techniques to stretch the tight adductor muscle while the carrying, playing, and dressing the child. Clear? I hope you are clear with the positioning part. Now we are going towards developmental strategies. So in this stage, you have to work on sitting, sitting balance, fine motor, and eye-hand coordination. Right? So you can achieve this by making strategy to strengthen the trunk muscle, enhance head and trunk control, and develop the trunk righting, equilibrium reaction, and protective reaction in the sitting. Next is sitting activity to develop and enhance sitting balance, and hand-eye coordination. So these are the activities: sitting with support, encourage use of one upper limb to play, bilateral upper limb engage in other activity, and weight shifting in the sitting. So now in this slide, sitting with support. First photo, child is seated on the tripod. Okay, tripod position with the support. In the second photo, child is seated supported using the assistive equipment. This is the assistive equipment for the supported sitting, and you can use while child is not surrounded by the adults. Second, encourage the use of lower one extremity to play. In first photograph, child is sitting on the floor without the support. There is no support. Okay, and playing using the one hand. Right. Now in second photograph, child is seated on bolster in straight sitting. Okay, with one hand supported on the table and doing the activity with other hand. So here this position help in reduction of adductor tightness as child is seated on stride position, plus also help to feel equilibrium as child is seated on the bolster. Now third is bilateral upper extremity activity, engage in other activity. In first photograph, child is positioned as previous photograph except the size of bolster. Here the reduced size of bolster is reduced. So reduced size require higher balance control. So as child gain proper balance control or equilibrium with uh, big bolster, you can move towards uh, smaller size, right? Now, playing with here the child is playing with both hands. Okay, so it also improve hand-eye coordination. And in second, child is sitting on the floor and playing with both hands. Here also child require hand-eye coordination to place the shape in the particular box. Now fourth is shifting and sitting. So you can achieve shifting by lateral reach out towards the same side. So in the photograph, child is reaching towards the ball on the left side. So his weight is shifted towards the left side. So it helps in develop equilibrium reaction. Now child achieves sitting goal. Okay. So we will move towards the higher level. So that is weight bearing. So weight bearing for the lower limb. So first weight bearing position in for the lower limb is kneeling position. So you can start it around 8 to 10-month old babies, right? So in the photograph, child is in physiotherapy department and position of child is kneeling position. Hand is using for the other activity. So and therapy is seated behind and helping the child to maintain the position by placing the hand over the gluteus maximus. But when you first start the activity, so especially for first time for the child, so therapist and child position same, but the child's both hands should be stabilized on the table. So uh, here the both hands should be stabilized on the table and mother should be seated here, and it help to hold the position. Now once the child acquire this position and gain the balance in this position, you can allow him to use one hand. So first both hands stabilize, second you can allow use one hand stabilize. Then again if he master in particular position, then bilateral hand can be used as describing this photograph, and then balance training in the position by the various reach out. So you can further go for advanced level, right? Next is for increase the lower limb, especially feet weight bearing initially, right? Hold the child in standing position and bounce on the parent's lap. But you have to take care for the good alignment of lower limb, right? So by bouncing, the child can bear the weight through the feet. Now you can also use varying surface for the bouncing, such as you can use foam, mat, or trampoline according to child's level, right? Now next is transfer. So transfer from one position to another help to child uh, be functionally independent, right? So if child is weak or paralyzed muscle, restricting transfer activity. So you can teach them compensatory method to cope with the situation, right? Either such as if child want to transfer from sit to stand, right? So for that child has required proper knee and hip extensor muscle, right? If child's muscle is weak to assume this position, so you can teach them alternate position, right? To sit to stand for the sit to stand activity. Or you can also prescribe adaptive equipment and mobility device as per child age. Okay. So for example, at the age of 10 to 12 months, or when child attempt to standing position, you can prescribe standing device such as standing frame, right? So standing frame which support trunk, hip and knee, while their hands would be free for the other activity. Okay. If the child is engaged in one activity with using hand, you can use standing frame for the longer period without getting irritated or making them tired, right? So always engage the child in playful activity while treating them. Initially start with fewer minutes and then increase the time gradually. Now in this slide, first photograph is RGO. RGO is reciprocal uh, gait orthosis. So it is basically hip, knee, foot orthosis, but in two parts. So there are two KFO for each leg, which are connected with the pelvic section. Okay, which help in pelvic rotation and help the child to walk without muscle control, especially when child is having very weak muscle. You can use these for the gait training or for the walking. Now second photograph is swivel walker. So swivel walker is you can use it for this standing position also. Child can walk in this walker. Okay. So what is it? So it support the hip, knee, trunk, and child also walk in this walker. Okay. And also it support the chest as well. These are also a swivel walker. Now here it is some activity in the standing. Uh, in photograph you can see child is standing wearing knee ankle orthosis. Okay. And therapist minimally asks the child to control the hip and knee. So here therapist, one hand is on gluteus maximus and one over the knees, right? So therapist is minimally assisting child. Okay. And child is playing with both hand in the front, right? So now tell me what is wrong in this photograph. So trunk, hip and knee are in the flexion. So how do you correct it? Okay. So here bring the foot slightly forward. Okay. Then increase the height of table. So up to this size, and slightly activate hip extensor and knee extensor. Okay. So by this manner you can achieve good position in and you can also play in this position, enhance hand-eye coordination by giving various activity to the child. Now once the child build up standing tolerance, so now child can stand for the 10 to 15 minutes in the walker or with the support. So what next level is to develop equilibrium in standing position too. So you have to develop balance in the standing position. For example, move in device, that is side to side transfer. Okay, side to side weight transfer. You can always achieve side to side weight transfer by the lateral reach outs, right? When the child shift weight, trunk muscle of the same side will be elongate. Okay, and uh, opposite side of muscles will be shorten, right? Now child develop balance in standing. So what is next? So our focus of the treatment should be teach them walking with walker or holding the furniture, right? But most patients with spina bifida have associated neurological conditions, which may lead to delayed developments. So not all the patient can reach this level in the stage 3. Okay. Now in this stage, there might be chances of getting complications of shunt malfunction or fracture. So here are some warning signs for the shunt dysfunction. So you can see the signs of hydrocephalus and swelling along the shunt side. So such as headache, irritability, vomiting, sleepiness, seizures, bulging of front annuli, and overhead size, right? And what are the fracture signs? So there might be local heat or redness or swelling and limb look misaligned, right? So we are done with stage 3. I hope you are now clear with stage 3 treatment. If you have any doubts, you can ask me personally.